Good afternoon, everybody. Thank you to our audience in the theatre that have attended, as well as our virtual audience online. My name's Vanessa McDonald. I'll be chairing the education session this afternoon. And it's with great pleasure that I introduce our international guest, Professor Mario Castro. Mario is from the Washington University School of Medicine, and his research interests are in the same things that we do here: asthma, COPD, chronic cough, and unexplained shortness of breath. He's part of the Severe Asthma Research Program and is a principal investigator of several networks looking at through the NIH, as well as the Patient-Centered Outcomes Research Institute. So he's very well published. We're very fortunate to have him here. Before I hand over, however, I will just kind of make a couple of notes in that once he's finished presenting, we'll have questions. For the people in the theatre, if you could ask your questions and then wait till it's repeated so that the online audience can hear your question. And if you've got a question from the online audience, type it into the little question bar or discussion bar, and we'll make sure that those questions are facilitated. So finally, before I hand over, I'd like to acknowledge and thank AstraZeneca for supporting this meeting here today. Thank you. And welcome.
Thanks, Vanessa, for that kind introduction. So, Vanessa, thank you for the kind introduction. Thank you for having me here. This is my first time to Newcastle. I've been very amazed by your respiratory institute here. It is quite impressive. Certainly one of the tops that I've seen around the world. And so you're very privileged to be working here, I think. I'm going to focus today in our severe asthma of how we use translational methods to really think about our patient population. I've been fortunate to be funded through the National Institutes of Health in the US through our Severe Asthma Research Program. And this is an endeavor for the last 18 years that we've been funded now. And it's, I think, been one of the most productive investments. Recently, Gene Bleeker presented at the American Thoracic Society the last 2 decades of SARP and totaled over 150 publications just from the SARP network. I take pride in that the leading group was the imaging group, which I lead in SARP, had over 30 of those publications. So I always start off with thinking about translational in terms of, I'm going to start with the patient and I'm going to end with the patient at the very end, because ultimately that's why we're here. This is actually a patient of mine that has severe asthma, and we use quantitative CT technology and other imaging technology that I'll talk about as we go, and how we use that within our approach to help us understand asthma. And ultimately, I think this will lead us to a more precise treatment of our patients. These are my disclosures. We have a number of different studies that we do for a variety of different companies. So I like to say that I'm equally conflicted across a number of different companies, and not anything particular for today's talk. So what's the unmet need in severe persistent asthma? Certainly, our patients are often still symptomatic. We are using guideline-based therapy with high-dose inhaled steroids in these patients and long-acting bronchodilators, and yet they're still symptomatic. And why? What is happening with those patients that are failing that control? And we also have biologics that it's exciting. We have 4 biologics approved, and we have others that are likely going to be approved. So we'll likely have at least 6 different biologics that we're going to be able to use for the treatment of asthma, as well as a device-based treatment. And this, how do we use these either in patient selection or how do we use it in combination? Hopefully I'll lead you to some insights of how we're going in that route. But these biologics that are currently used are focused on an allergic IgE-mediated pathway or an eosinophilic pathway, and really have no treatment options at this point for that non-eosinophilic group. That what I'm going to introduce to you is a relatively new phenotype called the mucus phenotype that I referred to, as well as a chronic airflow obstruction phenotype. And so these are areas that I'm going to focus over the next 40 minutes or so, and really how our understanding is evolving in this group of patients and potential options for treatment in these patients. So this is some data from our Severe Asthma Research Program. And as I mentioned, we've been following patients over an extended period of time, but in SARP-3, the third cohort, which we enrolled 700 patients, we were tasked really to follow them longitudinally. So SARP-1 and 2 had really done cross-sectional analysis, and most of the literature out there in severe asthma is really quite limited in that we only get a snapshot. And what we've learned from SARP, as demonstrated here in this third cohort, when you use the ERS-ATS definition of severe asthma, at baseline, we categorized about 56% of the patients. This was purposely recruited at baseline. And you can see that over time at year 1 and year 2, in these what we describe as Sankey plots, that there's movement of that population, some into that non-severe group, and then some from the non-severe group into the severe asthma group. So over a 2-year period of time, and now we've completed the 3-year follow-up, we're at approximately in the upper 40 percentile region in terms of persistence of severe asthma. So this is a phenotype that can be defined, and it appears to be persistent in the majority of patients. And there are some differences across age, which are quite interesting. I'm an adult pulmonologist, but I do both pediatric and adult research in asthma. And what we've learned is when you look at the same Sankey plots in patients with pediatric asthma, severe asthma, you can see that there's quite an evolution in children, and that down to about a third of those patients now 2 years out have severe asthma. So there's a lot more movement in pediatrics, a lot more evolving, as you can imagine, in this age group. And this age group was enrolled in the age group from 6 to 17 years of age. So we're really focused on older school age children and adolescents. Now, one of the things that we often were criticized in the first 2 cohorts of the Severe Asthma Research Program was that we really didn't account for non-adherence. So in SARP-3, we came up with a protocol where we administered during the initial characterization phase triamcinolone, 40 milligrams IM, and then we repeated the characterization after the IM triamcinolone. And this allowed us to basically, give them sufficient corticosteroid to look at what the message was in that regard for the patients. And what we found was that, and this study was published in the Blue Journal last year by Wanda Pipitonical, is that about 27% of the patients still had high eosinophil counts after the IM triamcinolone, and 36% still had high FeNO. And you can look at this, again, using these Sankey plots by categorizing these patients as either being T2 high, if their FeNO is greater than 25 parts per billion, and their sputum eosinophils are greater than 2% or greater, as a high T2 signature. So you can see that about 54% of the patients fit that signature in terms of T2 high at baseline. However, this does evolve, this does change. So you can see that, there are some patients that are moving into the T2 low group here, and also some of those T2 low group that are moving down here into the T2 high. However, at the end, about a little bit over half of these patients still were T2 high after 2 years. Now, when you look at categorizing them at either persistently low or persistently high or intermittently, they've been having one or more of these criteria within that 2-year follow-up period of time, it appears it's about a third, and a third. in that a third are persistently T2 high across the entire observation period, and then about a third are low, and then a third intermediate. And so I think this is one of the things that we have to change our thinking in our approach to these patients, and that this is oversimplistic to think of, the patient at this one time point is T2 high, and that's the way that patient's going to remain over a period of time. That's not true. Patients do evolve, their exposures evolve, and their phenotype also evolves, as demonstrated by this Sankey plot. Now, one of the things that we are pursuing now in an extension, a new SARP grant, is that we are really focusing our efforts into that T2 low subgroup of patients, because we feel that that group of patients really have insufficient therapies available for them at this point. And we also have evidence that this group appears to be less responsive to our mainstay of therapy in terms of bronchodilator therapy. You can see here the persistently low group in terms of their FEV1 change was markedly different than the persistently high T2 patients. And then if you look at that response to the IM triamcinolone, again, that group of patients had very little change in terms of lung function change to IM triamcinolone, very different than the T2 high group. And then on the far right panel is looking at the HOMA-IR index, which is a measure of metabolic dysfunction, showing that this index was elevated in these group of patients with that T2 high or T2 low signature. So we're actually focusing on what's driving this pathway. How could we understand the mechanism of action of this pathway in terms of metabolic dysfunction? What are the immunologic consequences within this patient population, to better understand how could we approach them therapeutically? And we are discussing some of those options in a new intervention network that's funded by the NIH called PRECISE. So our hope is that we can actually set the groundwork for tackling this group of patients that have that unmet need. Now, one of the phenotypes that I think is quite important in understanding is over a period of time that we've been observing these patients in SARP is what happens to exacerbations. We clearly know that exacerbation phenotype is a very labile patient, and we know that they also respond the best to the therapeutic interventions that we have currently available in terms of biologic therapy. So if you classify this, and this was recently presented by Lauren Dellinger from the Severe Asthma Research Program from UW Madison, showing that if you categorize these patients into not having an exacerbation in the previous 12 months, 1 to 2 exacerbations, and 2 or more exacerbations, or greater than 2 exacerbations, that this represents about a quarter of the patients that have greater than 2 exacerbations at baseline, and this actually does diminish over time. And we believe that part of this is being driven by just being involved in a study. You can imagine they're coming in for their visits, they have contact with healthcare system, and so I'm actually glad that this effect is going, but from a scientific standpoint, we wish we didn't have this impact, but there is definitely an impact on the patient population just from being involved in a study. And so what we've done is we've categorized these patients at the 2-year follow-up and now the 3-year follow-up, which we haven't shown that data quite yet, so it's not public, but it is very similar to this 2-year data, in that there is a group of patients that are persistently exacerbating, which represents about a quarter of the patient population. There is about half of the patients that have severe asthma that are exacerbation free, and then there's that group that's kind of in between that group. And so we're trying to understand better what are the mechanisms that are driving that exacerbation phenotype in these patient population. So what I'd like to next focus on is one group of investigations that we've been doing at Washington University in St. Louis, which is understanding what is the component of airway remodeling in this disease process in terms of severe asthma. So this was a study our lab published now about 10 years ago in the Blue Journal, where it was mostly just looking at a series of patients that were categorized based on their endobronchial biopsy and looking at the changes that occurred on the endobronchial biopsy. And what you can appreciate is this patient on the far right with severe asthma, their endobronchial biopsy looks very different than that individual with a normal individual that's non-atopic and non-allergic and non-asthmatic. Compare that also to the chronic bronchitis patient and the mild asthmatic patient here. And there are definitely differences in the airway epithelium. And when we quantified that, what we found was that the airway epithelium was increased in size. And we found that the lamina reticularis also was increased in size, as well as on the, and not displayed here, that there was increased smooth muscle mass. We also demonstrated in this particular paper that there was increased cellular proliferation in the airway epithelium, as demonstrated by Ki67 and by another protein that we looked at, retinoblastoma protein. And this was also confirmed by epithelial cell brushings and looking by expression. And then a tunnel positivity assay, which we conducted, which also demonstrated increased tunnel positivity. So basically the airway epithelium is proliferating and it's increased cell death, and that there's actually increased kind of a balance between this proliferative response and this apoptotic response to actually result in thickening of the airway epithelium in these patients. Now, what we've now evolved in since this paper now 10 years ago is trying to understand what's driving that thickness, what's driving that proliferation. And we believe IL-13 is key in that we know that IL-13 induces ciliated cells to become goblet cells. This is true in ALI cultures as well as and demonstrated in some other work we've done on biopsies. We also, in other work, have been shown that the ratio of ciliated cells to goblet cells is critical for mucociliary function. And so our hypothesis in this next phase of SARP that we're currently working on, and I'll show you some data from our lab, is that this remodeling process is likely being driven by increased goblet cell metaplasia, and that this is counterbalanced with actually a decrease of ciliated epithelial cells in the airway epithelium of patients with severe asthma when compared to healthy controls. So when we look at this data, keep this in mind. I'm going to come back to that hypothesis, but I'm going to interject here kind of throughout the presentation of how do we use the imaging component of this to help us understand the patient population as well. And so this is some recent work that Eleanor Dunnican published from the Severe Asthma Research Program in JCI this year, demonstrating that we can actually identify, just using quantitative CT, a mucus phenotype. And the way we did this is that we scored each of the segments of the lung on the right and left as either having a mucus plug or not. So each segment is either a 0 or 1, and then you could tally up those results in terms of mucus plugs, and you could come up with a scoring system that I'll show you next. And this is demonstrated in this patient here on the left in their CT scan from 2010, demonstrating this mucus plug here in the airway. And so, you know, we can look at this in a three-dimensional fashion and see that it's within the center of the airway. And we also know that there's far more mucus plugs present than bronchiectasis. Bronchiectasis was present in about 1 out of 5 patients, but we found a lot more mucus plugs. Over half of the patients had mucus plugs in their airways. So, and that's demonstrated here in terms of the presence of mucus plugs at baseline, and then the follow-up in terms of plugs on rescan. And this was in a subset of patients, about 25 patients that had repeat scans about 3 years later, as demonstrated in this patient that has persistence of their airway plugs in one segment, but not in this segment here. So you can see that, you know, about 80% of the patients have no replugs on rescan. So there's a, have plugs on rescan, or about a quarter of the patients do on rescanning. So it is a phenotype that does evolve, but there is this persistence of the mucus plugs that are identified in the high mucus score patient. So when we start to look at what's the implications of this mucus phenotype that we can identify by imaging, is that if you have a high mucus score, so you have 4 or more mucus plugs identified, that is correlated inversely with lung function. And in fact, these patients had marked airflow obstruction as demonstrated here. And then if you had a low score somewhere between 1 to 3, that was in this blue category. And then if you had no mucus plugs, that would put you in that 0 category. And you can see clearly a linear response in terms of lung function. Now, if you look at that Sankey plot, again, looking at over time, what happens, you'll note that the high mucus plug score in orange actually persists and actually grows to about 64% of the patient population. So it appears that the plugs appear to be persistent, and that there appears to be this mucus phenotype. Now, when we talk about this mucus phenotype, keep in mind these patients are taking high doses of inhaled steroids. They're taking long-acting bronchodilators, and this has no impact on this mucus phenotype. So definitely we need therapeutic responses or intervention for these patients. And what's interesting also is that if you look at what is the phenotype, the underlying phenotype in terms of T2 inflammation, these patients, they have evidence of the high mucus score being correlated with an increase in sputum eosinophils, as demonstrated here on the far left. You can see here the median almost 10, and you can see the range here in terms of mucus score. And then also, if you look at T2 signature associated from sputum, you can see that these patients with the high mucus score also had increased interleukin 13, as well as MUC5AC. So this was the MUC5AC to MUC5B ratio. You can see that the high mucus score patients also had an increase in this ratio, which makes a lot of sense. Again, this is from sputum though, but it's a nice correlation with what's happening on the imaging. So we believe that this is a phenotype now that we can quantify, we can track over time with imaging, and we can also use biomarkers such as the T2 signature. So our lab has been focused on what is driving that goblet cell metaplasia in these patients with severe asthma. We've been very interested in looking at the cellular population in terms of their evolving from the basal cell to Clara cells to ciliated cells, and then finally to that goblet cell, the mucus cell. And what was demonstrated in an earlier publication from JCI was that IL-13 is key in driving this transdifferentiation to a mucus cell, basically, that is non-ciliated, and that this is through a PI3 type mechanism, that EGFR receptor is also involved with this, and there's a number of inhibitors that have been shown to be effective in blocking this transdifferentiation. Again, this is all in vitro. And what we are testing now in vivo in humans subjects is basically how can we see whether or not this is truly happening in our patients with severe asthma? Could we capture basically a snapshot of this and see how they evolve over time with serial samples? And so we are using a number of different specimens to test this, number of different biomarkers as we list here to quantify the different cellular types that are within the airway epithelium. So we can actually test this hypothesis. Would inhibition of this epithelial cell apoptosis due to an EGF-dependent mechanism that then drives this IL-13 driven differentiation into goblet cells? So our hope is that, yes, we could potentially inhibit this process with IL-13 blockers or with other agents that are available clinically. And I'll talk about some of those results here subsequently. So this is another schematic that demonstrates that transdifferentiation in the epithelial cells that occurs, we believe, in a process where the cilia, we lose cilia, and I'll demonstrate some preliminary data in that regard, and it actually then becomes a goblet cell. And what cellular type that is, we are still identifying, but I'll show you some of our preliminary data in terms of what are the factors that induce survival, apoptosis, and this transdifferentiation, what are the cell types, and what are the role of other inflammatory cells that are in this milieu surrounding the patients. And we're using, again, a variety of different biomarkers to help us clarify this in our patients with severe asthma. So this is some recent data our lab presented at ATS last month. demonstrating in terms of the number of ciliated cells in the patient population from our Severe Asthma Research Program in the asthmatics in total compared to healthy. And then if you look at the subgroups of severe and non-severe, you can see that there's a decrease in the FOXJ1 expression in using confocal microscopy in these patients, and I'll show you some pictures of that in comparison to healthy individuals. So this decrease in ciliated cell appears to be driven by their underlying asthma, not necessarily different between severe and non-severe. And then, the key question is, does this result in increase in mucus accumulation in the airway? And so if you look at mucin expression in the airway epithelium, again, demonstrating as we have and other groups have an increased mucin intensity in patients with asthma. But interesting, if you look at the subgroups here on the far right, you'll note that the severe asthma group is quite different than the mild to moderate group of asthma, or the non-severe group. And so when we look at that using either MUC5AC expression or isocarmine immunohistochemistry, you can bring this out in terms of the goblet cells that are expressed here in the airway epithelium, and you can see quantifiable that there's an increase in these goblet cells that are present in the airway mucosa. And this is, again, key. It's the severity that appears to be driving this goblet cell metaplasia, not just a phenomena of asthma alone in terms of the disease pathogenesis. And then also in some, again, preliminary data, but some intriguing data suggesting that there is a correlation between this mucin expression and airway sputum eosinophils. You can see this correlation, though, is primarily driven by these 3 severe asthmatic subjects out here. But you can see that there does appear to be some correlation there. But interesting, we also found that there was an inverse correlation with sputum neutrophils. So the patients with more severe disease here actually had lower sputum neutrophils. So if you look at this quantifiable in terms of looking at the differential and clearly looking at those that have 2% or more eosinophils, you can see the mucin expression here is markedly different than the low eosinophilic group, the high neutrophil group, and also clearly a difference in terms of the number of ciliated cells that were positive in the airway epithelium, either by nuclei or by looking at the total area of the epithelium. And you can see that there's a marked and statistically significant difference between these 2 groups. So it appears that there's this relationship that occurs in patients in terms of severity of their disease driving the increase in goblet cells, but also this is being positively fed in this inflammatory eosinophilic asthma T2 phenotype. And then conversely, that this is inversely related to those with neutrophilic disease in this patient population. So we're carrying that forward in terms of understanding exactly what are the cell types that are driving this disease process, and hopefully then understanding how we could interfere with that. And we're conducting experiments now with air-liquid interface cultures to look at how could we interfere with this process. But as fortunate we are is that we're actually now developing biologics in the clinic that we can use to start to test some of these hypotheses. And so this was a publication did with one of our fellows a couple years ago that reviewed the literature, basically where we are in terms of phenotyping asthma. And these are 4 well-characterized phenotypes that we have available with severe asthma, what the biomarkers are that are associated with these phenotypes, and then the potential targeted therapies. Now, I'm not going to, again, spend much time on the eosinophilic group or this allergic group or the aspirin sensitive group, because there's certainly clear data out there that's been published. But I'm going to focus more on this mucus phenotype, this chronic airflow obstruction, and what are the potential therapeutic responses or therapeutic interventions that we can do. And so in some data that we published just this last couple weeks in the New England Journal of Medicine, we've published 2 phase 3 studies that looked at the effect of Dupilumab. And so as demonstrated in this cartoon, Dupilumab works because it binds with the IL-4 receptor, the alpha receptor. And fortunately for our intervention, the alpha receptor is present both for IL-4 and IL-13 signaling mechanism in both type 1 and type 2 receptors. And we know that these are T2 key cytokines that are driving inflammation in our patients with severe asthma, but also this drug has been approved now in the US with moderate to severe atopic dermatitis, so another allergic T2 driven disease. In a study that Sally Winslow was the lead author, we were involved with as well. In a phase 2 study, we demonstrated proof of concept that Dupilumab would work in patients with moderate to severe disease. And this is the study that we just published, and it's online, but coming out in print later this month in the New England Journal of Medicine from the QUEST study. So in the QUEST study, we demonstrated that if you look at exacerbations in patients treated with Dupilumab, it went down to around 0.5 exacerbations per year. So this resulted in about a 50% reduction in exacerbations if you received active treatment with Dupilumab. And it really didn't matter which dose of Dupilumab we used, either the 200 milligram or the 300 milligram dose. They were very consistent across all the different endpoints in terms of very consistent response between those two doses. In the phase 2 studies, phase 3 studies, we only use Q2 week dosing. In the phase 2 study, we have found that using it every 4 weeks was inferior with multiple endpoints compared to every 2 weeks. So every 2 weeks is basically what's being carried forward with Dupilumab, and also not shown here, but there was also significant improvement in asthma control as well as quality of life. And the one thing I want to lastly mention is on the far right here, is that what we're learning with these biologics is that very different from what we learned with inhibiting IgE with omalizumab, is that by inhibiting either IL-5 or in this case by inhibiting 4 and 13, you actually can improve lung function, which to me is quite remarkable. If you look at the improvement in FEV1 here, it was around 0.32 to 0.34 liters, and this was occurs very early, just after one injection. You start to see an improvement, a significant improvement in lung function. So not only you're reducing exacerbations, but you're actually improving lung function in these patients. Now, what about patient selection? So in this study, the QUEST study, we took all comers. They had to have at least one exacerbation in the previous year, but we did not select them based on eosinophils. We did not select them based on any T2 biomarkers. We took all comers. And so we wanted to explore basically what would be the effect at various cutoffs. And so this is looking at subgroup analysis. The far left here is the ITT population. So this is what I just showed you in terms of the overall patient population. And then when you look at those that have high eosinophils, you even see a more marked reduction in exacerbations, about 66 to 67%. If you look at a lower cutoff of eosinophils, 150 or greater, still 56 to 60% reduction in exacerbations. Now, what about the other group of patients that have high FeNOs? And so what we found out was very interesting was that FeNO actually was a very useful biomarker in this particular study. And so if you look at, again, the high FeNO group here, greater than 50 parts per billion, 70% reduction in exacerbations. And if you look at 25 parts per billion, still very marked reduction in exacerbations, 61 to 65%. Now, once they get less than 25 parts per billion, there was not a significant reduction in exacerbations. For sake of time, I'm not going to show you the lung function data, but mimic this basically the same kind of pattern that we just demonstrated with exacerbations. And the last thing is that when we looked at the subgroup of low eosinophils, but high FeNO, greater than 25 parts per billion, actually identified a group of patients that responded very well to Dupilumab. So we now have a treatment in that low eosinophil group that has a high FeNO as a biomarker that we could target with Dupilumab once it becomes available. Now, what does that mean? I think it means that there's likely this IL-13 driven mechanism from the airway epithelium that we can pick up on the FeNO signature, but we're not seeing elevated blood eosinophils in those patients. So hopefully, again, we will have this available in our clinic so we can treat that non-eosinophilic patient population. Now, the accompanying study that Klaus Rabi led in that same issue of the New England Journal of Medicine is the Venture study. And this looked at a smaller group of patients that were on chronic oral corticosteroids. They were on somewhere between 5 to 35 milligrams of oral steroids chronically. And we entered them into a dose titration to demonstrate that they had optimized their oral steroids before they were randomized. And what you see here is that there was about a 60% reduction in the oral steroid, there was a 60% reduction in the exacerbation rate in these patients treated with Dupilumab. And also there was an improvement in lung function. And then overall, there was a 70% reduction in the oral corticosteroid use. So despite being able to get their oral steroids down, this also reduced their exacerbation rate, but also improved their lung function. And this improvement in lung function was statistically significant. We did not see that with the anti-IL-5 studies with chronic oral steroids, neither in the Syria study nor in the Zonda study. But it's, we're still learning more about this patient population. But certainly, I think this is quite impressive that we're able to turn around these patients and get them off of steroids. Over half the patients were able to get off of chronic oral steroids. In terms of side effects, as demonstrated here on the very bottom, both in Quest and Venture, the main side effect that does need to be, I think, looked at in the future is eosinophilia and injection site reactions. So injection site reactions, which referred to as here as ISR, occurred in 9 to 17% of the patients, depending on which study you're looking at. And that just was related to the injection itself. But also eosinophilia was noted in these studies, around 14% in this one study and 4% in the Quest study. This eosinophilia, we believe, is related to the mechanism of the drug and doesn't necessarily translate to clinical symptoms, but this is being carefully looked at. So we believe that the IL-4 is alpha receptor blocking basically the eosinophils are being migrating from the bone marrow into the bloodstream and staying in the bloodstream. So it's not going into the tissue, but that needs to be demonstrated with some follow-up studies that are being performed in terms of looking at airway biopsies itself. Now, what's interesting is that in those patients with eosinophilia, they were to significant levels. So you're talking about 2,000, 3,000, 4,000, even in some patients, but yet did not result in clinical symptoms in those patients. There were, in this entire study, there were 2 patients that developed eosinophilic pneumonia that required a treatment that the investigator felt perhaps was related to the drug. So that needs to be followed up and see in the future, is there a potential for this drug that there is a clinical significant eosinophilic response? We don't know yet, is that significantly different from one would observe in this patient population alone. So the last part of that I like to focus on is this chronic airflow obstruction. And so we've been talking about perhaps modifying the IL-13 signature with drugs such as Dupilumab, which potentially would reverse that goblet cell metaplasia that we demonstrated earlier. But also another phenotype that really hasn't been addressed is leading to this chronic airflow obstruction that may be mediated by smooth muscle changes. And so again, this is where we use quantitative CT to help us measure this in our patient population. So this panel up here on the top, 2 panels are from a normal individual, and then the bottom 2 are from a severe asthmatic. And what you can clearly see from the airway epithelium is that in this severe asthmatic, that there's a very angry epithelium, a lot of goblet cells with this clear mucin that's present, as well as increase in this lamina reticularis. But we're also able to quantify this without doing endobronchial biopsies by doing quantitative CT. And this is just demonstration in this one patient where I marked where the biopsy was taken from and correlated that with the CT measure. And you can see here the average wall thickness in this severe asthmatic was 1.7 millimeters compared to the individual that had a normal individual. So this is just a graphic description of that. What we're doing now is with 3-dimensional software, we're able to measure this across all the segments and we're able to correlate that with the histologic measures that we're seeing. And this study that one of our fellows published now almost 10 years ago, demonstrating that if you look at wall thickness on the CT or wall area percent, that there is a correlation between that and the epithelial thickness that we demonstrated on the airway biopsy. A little bit weaker correlation with lamina reticularis thickness. And then interestingly, these measures were negatively correlated with FEV1% predicted. So clearly, as the patient became more obstructed, their FEV1 dropped. We saw increase in the wall area and wall thickness percent on the quantitative CT. So where are we going with these measures? This is some new data that just has been published this past year from our Severe Asthma Research Program in conjunction with our colleagues at University of Iowa. And this is where we're moving the field forward in terms of not just thinking about wall thickness in the airway itself, but looking at what's happening to the branching angles that occurs in patients with severe asthma. We believe, based on our preliminary data, that there's changes in the branches that occur in patients with severe asthma, as well as demonstrated here on the right, that there's differences in air trapping. And this can be quantitated using density measures and looking at differences between full inspiration CT and expiratory CT, either at residual volume or at functional residual capacity. And then also in preliminary data, we've also demonstrated that there are actually structural changes that are occurring in terms of the AP diameter that we've classically have seen, based on chest radiograph in the past, but we can actually look at differences in lung shape that occur in patients with severe asthma. And then this last is what we refer to as registration-based measures, where we're able to look at differences at total lung capacity and compare that to expiration. So basically the differences between inspiratory and expiratory CT, and you can actually measure in the areas that are normal lung where you see air trapping. And basically this correlates to small airways disease. So these are functional measures of small airways disease that we refer to as parametric response mapping, or the latest is disease probability mapping, or DPM. So these are the newest measures that have been developed in a recent publication last year. We demonstrated that just using these measures of CT, that you can actually cluster patients into these different clusters. And you can see, just for example here, the patient in cluster 4 has a decrease in their luminal narrowing, basically very narrowed airways, and that there's lung deformation that occurs along with that, as well as marked air trapping. And if you look at the clinical characteristics of these patients, you'll note that they're very different. They have late onset disease, they have significant dominant, neutrophilic dominant inflammation, and compare that to some of these other clusters. So we believe that this imaging is going to allow us to understand what are the different subset of patients, and potentially what are the characteristics that are driving that, so we can understand potentially how to intervene with this patient population. The last thing I'd like to share with you about some newer advances before I get into the therapeutic part of this is some recent work that has just been accepted by the Blue Journal, led by George Washko at the in Boston, basically showing that not only are there airway changes that are occurring in our patients with severe asthma, but there are vascular changes that are occurring. And that's demonstrated here in the patient with severe asthma. You can see the vascular tree is markedly different than that normal individual on the far left, or the moderate patient on the left. And you can see that if you look at vessel diameter, that there's differences here in the patients with severe asthma. And that's demonstrated here with this graph, where you see the vessel cross-sectional area in patients with severe asthma compared to the mild to moderate asthma. And this is clinically important, these changes in the vasculature that are occurring, because it was associated with lung function changes, peripheral and sputum eosinophilia, and was associated with their severity. And then lastly, as demonstrated in this table down here, if you had a low blood volume, BV5% or 10%, you can see that these patients had, in comparison to the high blood volume or normal patients, had a marked increase in exacerbation, the odds of exacerbation. So again, this is something we've kind of ignored, right, in the severe asthma literature, is really what's happening at the vasculature level, but there are accompanying changes, and whether or not they are causative or they're just associated with the changes that we're seeing in the airway, we don't know yet. But certainly, to me, it's very intriguing that we need to pay attention to that. So I'd just like to end with going back to a patient of mine. This is a fictional picture, so and fictional name, but this is a real patient, a 50-year-old male, early onset disease. So again, we're thinking about early onset disease, more T2 type of phenotype. Uncontrolled asthma, though, over the last 6 to 7 years. He clearly couldn't identify a trigger for that in terms of what caused that uncontrolled asthma, despite questioning him, but was hospitalized frequently and ended up on chronic oral corticosteroids, 20 milligrams per day. Now, when he saw us in our severe asthma clinic, his local pulmonologist had started him on mepolizumab over the last 3 months, and he was still symptomatic. He was short of breath on exertion. He was having nightly nocturnal awakenings, multiple triggers, and was really quite impaired in terms of his quality of life. He felt desperate. His wife came with him and said he's just not able to function. He had worked previously as a boat repairman, auto detailing, but those pains would trigger his symptoms, and he currently was employed at Walmart in our region. His concomitant disease, often in our patients with underlying obesity, obstructive sleep apnea, chronic rhinosinusitis, and had tried, our typical GINA 5 kind of step therapy with high-dose inhaled steroids, long-acting bronchodilators, and the prednisone and mepolizumab that I mentioned earlier. On his examination, he had end expiratory wheezing. His lung function was markedly reduced at 42% of predicted. But note here his bronchodilator responsiveness. To me, which is a good signal, right, in terms of airway remodeling, is that potentially, this patient can achieve near normal levels with an improvement in his FEV1 to 2.37 liters. He did demonstrate evidence of bronchial hyperreactivity, and we can talk about why we did this testing despite the bronchodilator reversibility, but it's part of our evaluation of these patients undergoing consideration for bronchial thermoplasty. On his CT, we do a TLC scan and we do a FRC scan to look at air trapping, and he did have evidence of air trapping. And you can see in terms of his biomarker assessment, keep in mind he's on 20 milligrams of prednisone here. His IG level was 79 and his eosinophil count was 150. And his asthma control test, unfortunately, my average is right around 8 in my severe asthma clinic, coming up in the initial evaluation of these patients, and he was right into that paradigm of around 6. So a year ago, a little bit over a year ago now, he was prescribed a LAMA-based therapy in addition to what he was taking because he had not tried that yet, and we switched his montelukast, his LTRA, to Xyluten, and we did the good things that any severe asthma clinic should do, right, in terms of reviewing his technique, making sure that his environment was addressed, and that he had an asthma action plan, and we also wanted to evaluate him for vocal cord dysfunction. So 6 months later, he returned to our clinic and really was still experiencing severe shortness of breath, severe paroxysms of cough. He was quite disabled, not able to, missing quite a bit of work, about 6 days from his job at Walmart, and was still using his beta agonist quite frequently, and was still taking 20 milligrams of prednisone. At that time, because he had just been started on the mepolizumab, we said, let's keep him on the mepolizumab for another 6 months and see what happens in terms of his control of the disease. And obviously now 9 months later, really had not achieved control on mepolizumab. So at that time, his ACT was 7. His lung function was still markedly reduced. He had a bronchoprovocation, with our laryngologist, he had a provocation testing and evaluated him for vocal cord dysfunction and did not have that. And then we carefully discussed with him potential approaches in terms of using anti-IL-5 therapy, whether or not to consider with going on to bronchial thermoplasty. And so In his particular case, he had already been reading about bronchial thermoplasty over this time period and really wanted to proceed with that as opposed to going in for injections. So how does bronchial thermoplasty work? Well, what's unique about it is it's the one treatment we have that we know modifies the smooth muscle. And this is just some data from one group. There are 4 independent groups now that have shown this. In this particular study, they did 17 patients with severe asthma, biopsies pre-bronchial thermoplasty, 3 and 8 weeks post, and they demonstrated about a 60% reduction. And you can see here in this representative samples, these smooth muscle bands in the same patient now after bronchial thermoplasty markedly improved. And what's interesting from this study is you can see a very consistent response in most patients, but not all patients. In fact, you can see this one patient here, there appears to be, an increase in that patient's smooth muscle area. So it doesn't necessarily work in all patients. And one of the theories is that perhaps you have to have a certain percent of smooth muscle area on your baseline in order to respond to this therapy. And this study suggested that that might be true. And in fact, if you look at the area at baseline, it correlated with the percent decrease in smooth muscle that was achieved, suggesting that if you really don't have much smooth muscle to modulate, that the bronchial thermoplasty is not going to work for you. So this was another group, the asthma study that was done, again showing very consistent results in this group, 73% reduction in airway smooth muscle. And interesting, in this group, they also demonstrated another effect, not just smooth muscle reduction, but also decrease in expression of these PGP positive neuroendocrine cells. So these cells actually decreased after bronchial thermoplasty, suggesting that the thermal injury that's done actually has a change that occurs in the nerve cell receptor expression. This correlated nicely with the clinical outcomes in these patients. And what was interesting was that there's a direct correlation between the decrease in airway smooth muscle and the clinical outcomes that occurred with bronchial thermoplasty. So where are we going with bronchial thermoplasty? Again, our group is very interested in how do you utilize imaging to potentially move this treatment that's now been approved by the FDA over 6 years ago. How do you move this to the next field, to the next level of care? And so one of our proponents is, again, precision medicine should drive us to targeted therapy. So what we're doing at this point is we're using hyperpolarized gas MRI to identify those areas of the lung that are remodeled that lead to ventilation defects. And so we use quantitative CT. We generate a mask from the CT to allow us to identify the segments. We combine that with our MRI, their hyperpolarized gas MRI, to identify where the segments are, where the defects are in the ventilation by segment. And then we can actually then measure that ventilation defect. So that's demonstrated here in a study that we recently completed, where these are 4 different patients here. You can see that in these patients that at baseline, how the gas distributed in their left and right lung. You can see that there are large areas here that are ventilation defects that occur. And you can see in this particular subject here, pretty marked ventilation defects in these patients where the gas is not going. So what we think is happening, and we've correlated this now, is that the airway is remodeled that's going to this ventilation defect. And then the thought is, could we potentially reverse that disease process? This mapping is basically a map that allows us to look and quantitate a well-ventilated lung, increase but not normal ventilation, and then basically no ventilation here on the far right. This is poorly ventilated, and this is no ventilation occurring. So you can actually see that there are segments of the lung where there's no ventilation reaching it. So what we've done is that we completed a study now of 30 patients, a pilot study, where we took half of the patients and we did targeted treatment. So we only treated those segments that had high ventilation defects. And we are comparing that to the other half of the subjects that are being treated conventionally with bronchial thermoplasty. With the thought is, if we could reduce this from 3 treatments down to 1 treatment, is that we can improve the safety profile for this potentially therapy. So that's actually what happened to the case that I presented to you. In Frank's case, he did receive bronchial thermoplasty in 3 different sessions. You can see here his number of activations across those 3 sessions. This is the last treatment in the upper lobe. And one of the things that I know here the group in Australia also has published is that we are very much a proponent that the number of activations that is delivered with the treatment is very important to adequately treat the smooth muscle. And so as you can see in this particular case, he did receive a significant number of activations to each of those regions of the lung. And this is his hyperpolarized xenon MRI. He did participate in the study. He, in this particular case, you can see what his pre-changes are versus his post. You can see these large ventilation defects now have reached near normalcy in terms of ventilation. So we believe that, again, that's reversing the disease process. I can't tell you if he is the targeted treatment or non-targeted treatment at this point because we have not unblinded the study. We are still completing follow-up in the patients. So our last patient is going to be followed up at the end of this year. And so stay tuned. Hopefully we can give you some results in terms of what does targeted bronchial thermoplasty occur. Now in Frank's case, I think is reason I bring this out is that this patient actually, as we evolved in his treatment, we actually demonstrated that he had persistent eosinophilia. So we continued to talk to him about an anti-IL-5 treatment. And in fact, in his case, towards his 3rd treatment, he started on benralizumab. And so when he started on benralizumab, he actually noticed that he could get through his last treatment, the 3rd treatment, even smoother. And maybe it's again because he had gone through the first 2 treatments, but he definitely noticed that. And then what was remarkable, we always follow these patients 12 weeks out from their last treatment, was if you look at his lung function, he had improved substantially. He now had improved to an FEV1 of 89% of predicted. I don't think this is due to the thermoplasty. I think this is due to the benralizumab, as demonstrated in that earlier data. There's improvement in lung function that occurs with an anti-IL-5 therapy that's been demonstrated both in the Sirocco and Kalima studies as well as the Zonda study. And we've not seen that traditionally with bronchial thermoplasty. Bronchial thermoplasty reduces the smooth muscle, but it does not bronchodilate. And so we don't see usually a change in lung function after thermoplasty. Along with this is his marked improvement in his rescue use, and he's now able to discontinue altogether his chronic oral steroids, and his ACT score now has improved to 20. And I share this case because I think it's really illustrative of that, when we think about the various biologic therapies that we have approved, which are in red here, outlined in red, versus those that are investigational, we have to think about that, our patients are much more complex, and that we can't just think necessarily that one agent is going to solve all the problems for our patients, that there may be suboptimal treatments, say in an anti-IL-5 treated patient, that perhaps there's another key mechanism that's important in that patient population. And whether or not we're going to be able to use these in combination, I don't know. Certainly none of them are approved to do that at this point. But as in my case, we felt that this smooth muscle component was so important that needed to be treated in addition to treating his eosinophilic disease. And so I think it's an exciting time because we're going to have these agents to treat our patients, and I think in a much more effective way with a much more acceptable side effect profile. So thank you. This is our signature in St. Louis, the arch at our downtown, which is the gateway to the west. Thank you very much.
Well, thank you, Maria. That was fantastic and covered all aspects of severe asthma management, which was great. I loved seeing the application of the imaging in order to select patients. Are there any questions from the audience? Jared.
Nice talk, Maria.
Yeah, thanks, sir.
I was wondering whether you have any evidence, even if it's anecdotal, of the patients that respond to anti-IL-5, whether there's actually reversal of any of the modeling that you see in the machine biopsies.
So I might just repeat the question, or you can repeat the question. But
sure. So the question was, for those that have been treated with anti-IL-5, is there any evidence of reversing disease remodeling, basically? So there is very small amount of data so far. And so actually from the original mepolizumab studies from 2009 that were published in the New England Journal of Medicine, there was a very interesting part that was in the supplement of that study from the Hadar group. And in that study, they actually studied 25 patients and did measurements of the right bronchus, RB1. And they demonstrated that the thickness of the airway in RB1 actually decreased with mepolizumab in comparison to the placebo group actually got worse. They had worsening thickening of their airway disease in the upper lobe. Again, this is a small group, 20-some patients that were treated in that particular study. We are following that up with other studies that are, we're focused on both with benralizumab as well as with Dupilumab to use imaging modalities to see whether or not the disease process is being remodeled or being changed that has previously been remodeled. And I believe that we will see some changes from that, which would be very exciting.
Lisa.
Hi, thanks for that talk. It was great. Earlier on in your talk, you described severe asthma in terms of the level of Th2 inflammation. You mentioned a group that was low Th2 but had high insulin resistance.
Mm-hmm.
So I just wondered, what do you think is the relationship between the inflammatory phenotype and insulin resistance? And was there other features of that group? So did they have high BMI? Did they have systemic inflammation?
Yeah, so we're still learning about that group, you know, in terms of the characteristics. So it does appear to be increase in IL-6, serum IL-6 greater than, we used a cutoff of 3.2 in that study demonstrating that there was an increase in IL-6. Michael Peters was the first author in that particular study. There is a relationship with BMI as well. And what's curious is that that relationship is present with IL-6, but not necessarily present with other T2 markers in that particular paper as well. And we're in PRECISE, we're actually considering doing targeted, selecting that patient population and then using an inhibitor of IL-6 as a potential therapeutic target.
So what's the reason for labeling it the high overnight rather than labeling it a high IL-6 group, for example?
Well, I think, you know, we're going to enrich the patient population based on probably the HOMA-IR, but we are going to use as a predictive biomarker and potentially a response biomarker, but we have no data on that yet, the serum IL-6. So it's a combination of how do you select the appropriate phenotype that you're going to target with the therapy, and then do you have a biomarker that's going to help you manage in that particular patient, and that's how we're approaching it in that particular study.
Nathan?
Thanks, Mario. I'm wondering how you reconcile the non-responsiveness of the mucus high phenotype to steroids when it's linked to a T2 high group, which tends to be quite steroid responsive. How do you reconcile that, and what do you think? Is there a role for steroids in inducing mucus, do you think?
Yeah.
Just repeat the question.
Oh, okay. Oh, that's right. We forgot to repeat that last one. So the question is, how do we reconcile the high mucus plug phenotype with those patients that are being treated with high doses of steroids? And then the last part you mentioned was? Well, yeah, and they tend to be linked to a T2 high phenotype, which tend to respond well to steroids. Right, right. And because of that correlation that we showed with the high T2 biomarkers, and those tend to respond to steroids. Exactly. So I think it's very interesting, right? I mean, to me, it's fascinating because the patients teach us so much more than, you know, what we can manipulate easily in the lab sometimes. And so what's interesting is when they removed the mucus plugs in a subset of those patients, they identified that the eosinophils were infiltrating in that mucus plug, not necessarily in the mucosa, but in the plug itself. And there was high expression of eosinophil cation protein in those patients. And the thought was that, and some also data that was shown in that paper, is that there was cross-linking of these thiol groups that was forming this mucus plug in those patient population. So I think that this is a downstream mechanism that occurs in these patients that leads to their chronic airflow obstruction that is not impeded at all by the steroids. In essence, it's like the eosinophil really poured out its toxin and it's doing its damage and not necessarily being impeded by the steroids. Perhaps now with anti-IL-5, we can reverse that disease process or at least prevent its progression, which is really, I think, where we need to be. Yes.
So can I just ask a question on the mucus phenotype? Because I mean, I'm really interested in it because it has huge burden in terms of patient outcomes. And you said that the steroid or the LABA have no effect on it. What about LAMA?
So at this point, we don't think LAMAs have any effect on it. It is a smaller subset of the patients in SARP that are being treated with LAMAs, but it doesn't appear to impact on that mucus phenotype at this point. And so, you know, when we do these studies on the CT, we do them after maximal bronchodilation. So these are plugs that are in the airway that are not being impacted by bronchodilators at all. Great.
No,
sorry, we've done this room.
Oh.
All right.
Well, I'm glad I asked the question then.
All right.
Okay, so I think that's our cue to wrap this up. But please join me in thanking Mario. I think that was an excellent session. And we're really grateful that you could be here. Thank you.
Thank you.